Hello everyone, welcome to Nurse Bestie Explains. Today I am here with another video of 10 more important OBG and midwifery nursing VIVA practical exam questions. I hope previous videos are good. If any doubts you have, you can always ask and comment for a clarification. Let's continue with few more questions. That is PPH. Okay, that is nothing but postpartum hemorrhage. That postpartum, after the delivery hemorrhage. It is severe bleeding after childbirth, defined as losing 500 to 1000 ml of blood within 24 hours. Then only we call it as postpartum hemorrhage. 5 to 1000 ml of blood within 24 hours after the delivery, often causing hypovolemic shock. If the mother loses 1000 ml of blood, mother will go into, due to less volume of the blood, she goes into shock. It is a leading cause of maternal mortality, typically treated with uterine massage, medications like oxytocin, tranexamic acid, or surgery to stop bleeding. Key causes include uterine atony, losing the uterine atony. Once the baby is delivered, the expanded uterus should come back to its normal pre-pregnant size. If it fails, uterine atony is affected, it may lead to PPH. Trauma, retained placenta, any placental parts retained inside without complete removal, that also leads to PPH after the delivery. And coagulation issues. If mother is facing with blood coagulation issues, the blood will not clot, so continuous bleeding she will observe. Signs and symptoms of PPH are uncontrolled or heavy vaginal bleeding, decreased blood pressure, mother goes into hypotension, decreased blood pressure, increased heart rate tachycardia, decreased red blood cell count, that is anemia, dizziness, lightheadedness or fainting. Mother may feel dizzy, lightheaded and she may faint. Swelling and pain in the vaginal or perineal area if a hematoma is present. Hematoma is a clot, pooled blood clot formation at the vaginal or perineal area. Types of postpartum hemorrhage: primary PPH and secondary PPH. Primary is early occurrence, secondary is delayed. This primary occurs within first 24 hours after delivery. Secondary PPH occurs 24 hours to 12 weeks after the delivery. Coming to the management of PPH, usually this will not be asked in VIVA because the PPH management is very big. But in brief, if they ask you, just explain me in 4 steps how you will manage the PPH, you will be able to explain if you go through this. Okay. If the mother observes PPH before placenta still not delivered and she is observing lot of loss of blood, okay, that time give injection oxytocin 10 units IM or IV. Start 20 units oxytocin in 1 liter normal saline drip at 60 drops per minute. If placenta retained inside, placenta not delivered within 30 minutes after delivery, do controlled chordate action. Okay, CCT, controlled chordate action you have to apply. If controlled chordate action fails, do manual removal of placenta. Insert your hand and manually separate the placenta from uterine walls and remove it. If retained products of conception, placenta is removed but some pieces of conception are remaining inside. Portion of placenta or membranes are missing. Remove placental fragment membrane by exploration of uterus using hand. Insert the hand, remove the leftover parts. Sponge holding forceps or large curette you can use. If placenta is still retained, bleeding continues, bleeding is controlled. If bleeding continues, injection ergometrin 0.2 mg IV, misoprostol for 800 to 1000 micrograms, stat and continue for 6 to 8 hours. Blood transfusion you have to start because mother is losing blood, and exclude genital tract injury, exclude DIC, disseminated intravascular coagulation, and antibiotics has to be started. If bleeding is controlled, continue 20 units oxytocin IV in 1 liter normal saline at 20 drops per minute for 4 to 6 hours. Even though bleeding is controlled, you have to continue the oxytocin with NS drip. Transfuse blood if necessary. Iron, that is ferrous sulfate and fumarate 150 mg, folic acid 400 micrograms oral. Daily for 3 months you have to advise. Note, very adherent tissue may be placenta excreta. When removing with the hand, if placenta is very adherent, stick to the uterine wall, not able to separate it, that may be one type placenta excreta. If placenta is delivered, after delivery, mother started with PPH. Okay, uterus fails to contract after delivery. Because of this, mother is having PPH, use oxytocin drugs. Oxytocin 10 units IM plus 20 international units in 1 liter NS IV drip. You have to start injection ergometrin 0.2 mg IV, misoprostol, catheterization, uterine massage, tranexamic acid slowly 10 cc IV oral 1 gram, transfusion of the blood. Then if still bleeding persists, rule out for DIC, aortic compression, bimanual compression, exploration of birth passage for injury and retained placental fragments. Retained products you have to observe and remove the retained products. Intrauterine ballooning by condom catheter. You can insert condom catheter. Intrauterine ballooning can be done. Laparotomy, stepwise devascularization of uterus, D-link suture, uterine and utero-ovarian artery ligation. All these are the different conservative interventions which you can perform to control the bleeding. If uterus is contracted because of trauma, if the mother is having PPH, examine genital tract, tear of any cervix. While baby is delivering, sometimes tear of cervical wall or vagina, perineum, that has to be repaired. Vulval hematoma or bleeding from episiotomy wound. Episiotomy we give a cut at the perineum. So because of that there is a wound, open drain repair has to be done. Ruptured uterus, subtotal hysterectomy or total hysterectomy. If the uterus is ruptured, you cannot control bleeding. Mother will go into hypovolemic shock. It may lead to death also. So complete hysterectomy, total or subtotal hysterectomy is advised. If the cause is DIC, bedside clotting test, no clot after 7 minutes or clot breaks easily, give fresh whole blood, treat the cause. And inversion of uterus. Sometimes uterus is inverted. Okay, uterus inside out, within or outside vagina, severe pain and shock occurs. Injection pethidine IM 1 mg per kg for pain. Reposition the uterus immediately under general anesthesia. Advise antibiotics if reposition not possible. Then refer for emergency surgery. Okay, this is the management. Generally, identify the cause, start injection oxytocin, ergometrin injection has to be done. Identify the cause because depending upon the cause, management is given. Ergometrin and oxytocin with IV, normal saline 1 liter IV drip has to continuously flow, then blood transfusion. These are very important aspects which we need to remember. Next question is lochia. In the puerperal period, postpartum period, we will observe these bleeding stages. Lochia is the normal vaginal discharge consisting of blood, mucus and uterine tissue that occurs 4 to 8 weeks after the childbirth. Mother will have bleeding for up to 4 to 8 weeks. It happens as the uterus sheds its lining, heals, all that leftover lining of the uterus, everything will shed off in the form of this lochia. Regardless of delivery method, whatever cesarean or vaginal delivery, mother will have bleeding up to 4 to 8 weeks after the delivery. It typically moves through 3 stages. Okay, there are 3 stages: lochia rubra, lochia serosa and lochia alba. Lochia rubra is observed from day 1 to 4 postpartum days, where there will be heavy, dark, bright red, possibly small clots also can be observed. Dark, bright red color bleeding can be observed. Lochia rubra. Then lochia serosa. Day 4 to 10 postpartum you will observe light red or pinkish brown color. That means old blood. Okay, pinkish brown color blood can be observed. Third one is lochia alba. That is up to 6 weeks postpartum this can be observed. More yellowish but can be mixed with spotting sometimes. So lochia rubra, lochia serosa, lochia alba, very important VIVA question. Next, obstetrical disorders. Hyperemesis gravidarum, you already know it is deficient. Hyperemesis gravidarum is a severe form of nausea and vomiting in pregnancy that goes beyond the normal morning sickness. Usually every pregnant mother will have a nausea and vomiting morning sickness, but it goes beyond that. Some mothers due to hyperemesis they get admitted for fluid balance. It can lead to dehydration, electrolyte imbalance, weight loss, and nutritional deficiency. The causes are elevated human chorionic gonadotropin hormone, high estrogen levels, multiple pregnancy, if mother is pregnant with more than one baby, psychological factors like stress, anxiety, gastric or metabolic disorders. Risk factors are first pregnancy. Usually first pregnancy, mothers will face hyperemesis gravidarum, multiple gestation, history of hyperemesis gravidarum, obesity, trophoblastic disease. Then complications include dehydration, electrolyte disturbance, malnutrition, Wernicke's encephalopathy, renal failure. Management includes general measures, hospitalization if severe, rest and reassurance, small frequent meals. Do not dump like lunch, heavy dinner. She should not take small feeds at frequent intervals. Dry foods, avoid spicy, fatty foods. Medications, antiemetics like ondansetron, metoclopramide, and promethazine, vitamin 86, pyridoxine. Nutritional support, high calorie diet. If severe cases, enteral or parental nutrition. Okay, this is hyperemesis gravidarum. Next one is hydatidiform mole. Molar pregnancy. We call it also as a molar pregnancy. Okay, regular pregnancy looks like this, where embryo embeds into the uterine wall, starts growing. Whereas in molar pregnancy, fluid-filled cysts or tumors like you can observe in the uterine wall. A hydatidiform all molar pregnancy is a rare non-cancerous tumor. It is non-cancerous that develops in the uterus due to abnormal fertilization. It occurs when placental tissue grows. Placental tissue grows abnormally into like a mass, often described as bunch of grapes. You can see here like cysts, like so many sacs. Okay, so that is bunch of grapes with little or no fetal development. There won't be any fetal development. Instead, this bunch of fluid-filled cyst, tumor-like but non-cancerous, starts growing in the mother's uterus. It is a form of gestational trophoblastic disease. Okay, it is a type of GTD, gestational trophoblastic disease, that requires a surgical removal, like with suction and curette, surgical removal of this cyst. That is hydatidiform mole, also called as molar pregnancy. Next one is ectopic pregnancy. An ectopic pregnancy occurs when a fertilized egg implants outside the uterus. Usually, after fertilization, that travels into the uterus and it is implanted into the wall of the uterine body. But in ectopic pregnancy, outside the uterus, most commonly in a fallopian tube, you can observe sometimes in the ovaries also, it takes place. Then in the fallopian tubes, isthmus, interstitial layer, sometimes in cervix, peritoneal cavity also. Okay, making the pregnancy non-viable, potentially life-threatening. This is life-threatening situation for mothers. Symptoms include same like pregnancy symptoms. Mother will observe missed periods, vaginal bleeding, and pelvic pain, usually appearing 4 to 12 weeks into the pregnancy. Immediate medical treatment is necessary to avoid rupture and severe internal bleeding. So this is about ectopic pregnancy. And if you see the types of ectopic pregnancy, interstitial 2 to 3% cases we can observe, that is here embedded, the development of embryo in the interstitial layer. Ischemic pregnancy 12% at the isthmus part. Ampullary pregnancy, ampulla of the fallopian tube, 70% of cases commonly seen this one, ampullary pregnancy. Fimbrial pregnancy 11%, ovarian, development of embryo in the ovaries. Cervical pregnancy at the cervix, 1%, abdominal pregnancy 1%. So these are the types of ectopic pregnancy. Next topic is abortion. Definition: abortion is the expulsion or extraction. Sometimes miscarriage happens without any attempt. So that is expulsion of the fetal material or extraction from its mother of an embryo or fetus weighing 500 grams or less when it is not capable of independent survival. Abortion occurs. Okay, that is abortion according to WHO. Types of miscarriages or types of abortion. There are 5 types: missed, threatened, inevitable, incomplete, and complete abortion. If you see the missed abortion, no vaginal bleeding you can observe here, closed cervical os, no fetal cardiac activity or empty sac. Sac will be empty, fetal cardiac activity will not be observed. Threatened abortion, vaginal bleeding will be there, closed cervical loss, fetal cardiac activity present. Inevitable abortion, you can see in the picture, cervical loss dilated, vaginal bleeding will be there. Products of conception, okay, whatever the products of conception may be seen or felt or above just the cervical os. Incomplete abortion, vaginal bleeding, dilated cervical os, some products of conception expelled and some remain inside. Some products are expelled in the bleeding, some remain inside. That is incomplete abortion. Complete abortion, vaginal bleeding will be there, closed cervical os, products of conception completely expelled out. Okay, these are the types of miscarriages. Then hydramnios. Okay, hydramnios or polyhydramnios, it is the accumulation of excess amniotic fluid around the baby in the uterus. You can see in the picture, excessive accumulation of amniotic fluid around the baby in the uterus is called as poly. Okay, poly is extra, excessive. Hydramnios is amniotic fluid. It occurs when there is an abnormal buildup of amniotic fluid more than 2000 ml. Okay, more than 2000 ml, that condition is called as polyhydramnios. It is diagnosed via ultrasound, specifically looking for an amniotic fluid index 24 to 25 centimeters. Okay, greater than this or a single deep pocket more than 8 centimeter. And the other conditions are there, that is oligohydramnios, that is low amniotic fluid. This is the normal healthy amniotic fluid where baby will have more room, space for movement, easy movement, flexibility is possible. Here low, because of low amniotic fluid due to oligohydramnios, where space will not be available, so baby's movement is restricted. Okay, polyhydramnios and oligohydramnios. If you see here, we have already seen extra accumulation of fluid. 0.2 to 1.6% of all pregnancies can be higher in women with diabetes and gestational diabetes. It can also be picked up on ultrasound. Usually this condition is observed, and also when you check the gestational age or fundal height more than the mother's gestational period, you will observe bigger belly. Okay. Next topic is RH incompatibility. Okay, this occurs when an RH negative mother, RH negative pregnant mother carries a RH positive fetus. Okay, mother will be RH negative but carries a baby who is RH positive. Because of this, what happens? Her immune system will react and it will create antibodies that attack the fetal blood. But one thing you have to remember, not in the first pregnancy. Okay, this condition known as sensitization typically does not affect the first pregnancy but poses risk to the future pregnancies, because in first pregnancy she will develop antibodies which will not affect the first baby, but when she becomes pregnant the second baby will be affected. That's why RH immunoglobulin injections are usually given around 28 weeks and after delivery. Okay, you can see here RH incompatibility during pregnancy. This we have already seen. Okay, how does it develop during pregnancy? RH mother recognizes RH cells as foreign, so her immune system will react and antibodies will be developed, because of which first pregnancy will be affected and subsequent will not be affected. Subsequent pregnancies, babies are at risk for developing what? Baby will develop erythroblastosis fetalis. That means severe anemia, jaundice, heart failure or brain damage, and sometimes it can be fatal. How to prevent? Injection of anti-RH antibodies to the mother during the first pregnancy, given to the mother immediately after first delivery. Also after miscarriage or any abortion occurs, immediately you have to give this injection, so second pregnancy baby you can protect. Next topic is multiple gestation. A multiple gestation occurs when a woman carries two or more fetuses. You can observe more than one fetus. Okay, it can be twins, triplets, quadruples. Okay, it is considered as a high-risk pregnancy, frequently resulting in premature birth. Diagnosis is usually via ultrasound early in pregnancy, which identifies the number of fetuses for twins if they share a placenta or separate sacs. Okay. So after doing ultrasound, they will observe whether they are sharing same amniotic sac or placenta. Here if you say, according to that, the terminology is given as Monochorionic, monoamniotic. Okay, one same placenta they will share with two different umbilical cords and one amniotic sac. They are called as monochorionic, monoamniotic. Second, monochorionic, diamniotic. Okay, same placenta they share, but amniotic sacs different. Dichorionic, diamniotic. Okay, fused placentas. Okay, two placentas but fused and different amniotic sacs. Dichorionic, diamniotic. Two different placenta, two different amniotic sac. These are the different types of multiple pregnancies. Next, a small question for you. Please think and answer this. Cephalopelvic disproportion is diagnosed when? Do you know what is cephalopelvic disproportion? I hope most of you know by now because you are preparing for examination. So what is CPD, cephalopelvic disproportion, when it is diagnosed? Option A, cervix not dilating at the time of delivery on the delivery table. If cervix is not dilating, that time you will guess this. Or fetal head cannot pass pelvis, FHR abnormal, BP, high fetal heart rate abnormal, that time you suspect for this. Or BP of the mother is high. What is the answer for this? Can you guess? Any guesses? Okay, the answer is option B. Fetal head cannot pass through the pelvis even though there is cervical dilatation. Still there is no effacement. Descent is not taking place. That time you can suspect for cephalopelvic disproportion. Okay, CPD is a condition where the baby has trouble getting through the birth canal because of the size of the baby's head, position of the baby, or size or shape of the mother's pelvis. CPD is a rare childbirth complication occurring when a baby's head is too large. Okay, it occurs if the baby's head is too large or the maternal pelvis is too small. Okay, if it is not gynecoid pelvis, which will not help in normal vaginal delivery. This mismatch causes arrested or slow labor, requires a cesarean section. There are fetal factors, maternal factors, and there is group. Fetal factors are if the baby is large, macrosomia, fetal head in an abdominal position, that example occiput posterior position, okay, or congenital anomalies related to head. Okay. Maternal factors like pelvic size is small, non-gynecoid, abnormally shaped pelvis, or skeletal abnormalities caused by previous pelvic fracture. Mother had any history of accidents, any pelvic fractures, or any conditions like rickets which occurs due to vitamin D deficiency. Any such history is there, due to that also it leads to CPD. Risk groups are more common in adolescents and individuals with shorter stage. This is about CPD. Okay. So this is the brief revision of the 10 more important questions of OBG VIVA for the practical exam. Like, comment, share, subscribe, and thank you for watching. Keep following for more videos.